Great, thank you so much thank you. It's always an honor to be back at the Lakewood Church, and I appreciate the opportunity to speak to you this morning. I'm going to be interesting problem of what we sometimes call neglected tropical diseases, or NTDs, and the need to make some innovations for this. So this is an interesting side to the whole medical missionary concept, the idea that we also have big gaps in research and development for diseases of the poor. So I'm the Dean of the National School of Tropical Medicine at Baylor College of Medicine, and I'm also the head of the Sabin Vaccine Institute and Texas Children's Hospital Center for Vaccine Development. And one of the takeaway items from this is if you're in Houston and you ever want to come visit our labs and see how we're making the vaccines that the big drug companies can't make or won't make, and how we're making them in the nonprofit sector, I invite you to give you a tour of the labs and talk to our scientists. I know Vernesta would enjoy doing that. Raise your hand, Vernesta, so she's our go-to person here. I'm going to start here and talking about the Millennium Development Goals. How many have heard of the Millennium Development Goals? So most of you. So these are the agreed upon goals that was set by Kofi Annan, the Secretary General of the United Nations in 2000s, to lift the bottom the billion people in the world who live on nothing, live on no money, out of poverty. And those are the 8 goals listed there. There are several that are related to health, which includes reduced child mortality, combating AIDS, malaria, and other diseases. And I'm not a big fan of United Nations documents. I think they tend to be forgotten about as quickly as they're drafted. But this one has stuck and has provided a 15-year framework for understanding and addressing the plight of people living in poverty, including some big picture initiatives that were directed at health. The other thing that was very exciting about it is it drew in a big component of advocacy and the celebrity community. So we got Brad Pitt on the bottom there doing a 4-part series on the Millennium Development Goals for public television. And of course, if you get Brad, you get Angelina also, and George Clooney lent his voice, and President Bush launched PEPFAR, the President's Emergency Plan for AIDS Relief, and Bono, of course, the One campaign, and Bill Gates got involved. This all happened in association with the Millennium Development Goals, and it was really a game changer for the world's poorest people. And I want to go do a little deeper dive on 2 of these goals that where we had the biggest impact, because now they were scheduled from 2000 to 2015. We're now at the end of the Millennium Development Goals and about to embark on a new set of activities. And I'd like to kind of tell you what some of the progress has been. So here is the 4th Millennium Development Goal, to reduce child mortality. And the big approach there was to focus on providing vaccines for children. So these were the vaccines that were already on the shelf, like measles, whooping cough vaccine, diphtheria vaccine, tetanus vaccine, but also to make some new vaccines like for pneumococcus and rotavirus infections. And we're now in a position to evaluate their impact. This is a paper that I'm actually on somewhere in the middle. It looks like a paper out of the CERN physics laboratory, but it's an initiative that's based at the Institute for Health Metrics and Evaluation in Seattle, and it's supported by the Gates Foundation. It's called the Global Burden of Disease Study, and the idea behind it was the Gates Foundation supported it. The idea was we're now going to aggressively look at what the impact of all of these big initiatives that were launched at the 2000 Millennium Development Goals to see if we really made a difference and really made an impact. So we brought together hundreds of scientists trying to determine what the impact, for instance, has been on Millennium Development Goal number 4 in terms of providing all of these vaccines for children across the planet, and also introducing some new vaccines. And the first part of the story is a really good news story. This has been the impact over the last 20 years. Pretty impressive stuff. 83% reductions in measles deaths. So measles went from being the leading killer of children, hundreds of thousands of deaths every year, to under 100,000. Still a lot of children dying, but a big impact through these initiatives such as the Global Alliance for Vaccines and Immunization, through the Decade of Vaccines launched from the Gates Foundation. It made a difference. And this is very important also when you're going back to Congress, because members of the House of Representatives and the Senate, they want to know that if we're using taxpayer dollars for some of these initiatives, that it's having an impact. And sure enough, it is. An 82% reduction in tetanus deaths, a 57% reduction in diphtheria deaths, Haemophilus influenza type B deaths. This is all because of increased and expanded use of vaccines. And the two newer vaccines that got launched over the last decade, which includes for pneumococcal disease, that's newer, so that's a less of an impact, but that's rapidly growing. And a 63% reduction in deaths from rotavirus, which is the major cause of childhood diarrhea. And the estimates are that there's been 2.5 million child lives saved through these initiatives. So that's pretty exciting stuff. And on I guess the top got cut off a bit, but what it's showing you is there's this big drop in under 5 child mortality, dramatic decreases, mostly because of the impact of vaccination. Now, there's a not so good news component to this story as well, which is actually we're reversing our gains in the United States. So what's happened is there's been a very strong anti-vaccine movement that's erroneously tied vaccines to autism, and I'll explain why there's no link for that in a minute. But what we saw, for instance, was a dramatic rise in measles cases in California, and that's a serious thing to be worried about, because measles at one time was the leading killer of children in the world, and the only way it went down is because we started vaccinating young children. So we're starting to see now this rise in measles and other vaccine-related diseases. And we're seeing some scary stuff going on in our state as well, where there's right now Texas ranks at the bottom of fully immunized preschool children. We're at the bottom with West Virginia of all 50 states. There's been now 41,000 personal belief exemptions in Texas, meaning parents who opt their children out of getting vaccinated. So I've just wrote in the Houston Chronicle a couple of weeks ago that it's not whether we're going to see a measles epidemic in Texas. We will see a measles epidemic in Texas. And it's unfortunate because it's preventable. The reason I get involved in this component of the issue is I have a daughter. My youngest daughter has severe autism and a lot of other mental disabilities. So I'm in this very interesting position where I'm making vaccines for a living, but I'm also a parent of a child with autism. And one of the things that I've been saying is, in addition to the studies that show there's no link between vaccines and autism, the science there's no plausible mechanism by which a vaccine could cause autism, because we now know from studies such as this, which is that the pattern of disorganization in the neocortex of children actually is almost complete by the first or second trimester of pregnancy. So the changes you're going to see in autism are due to genetics and epigenetics, and it's basically a done deal by the second trimester of pregnancy. And so whether or not you vaccinate or don't vaccinate is going to have absolutely nothing to do with autism. And so it's very important, I think, to get that message across, because it's very sad to see the enormous gains that we're seeing in the Zimbabwe's of the world we're not seeing in the United States, and the irony is incredible. The other thing that's happening now in the U.S., we like to export our culture. We export our Hollywood movies. We're also exporting what we sometimes call vaccine hesitancy as well. So now the same anti-vaccine attitudes are now getting exported to India, Nigeria, and elsewhere. And can you imagine what's going to happen when we start seeing drops in measles vaccination or whooping cough vaccination? We could be looking at a real catastrophe. The other important Millennium Development Goal is this one, number 6, to combat HIV, AIDS, malaria, some people add tuberculosis, and other diseases. And for that one, we're also seeing a big impact as well. Now, this is half the author list here. And if you see, you can find me. Where's Waldo? You can see if you can find me on the list. And this is just half the author list. So this is a lot of work to really measure the impact of these. But what we've seen on the right there is from what President Bush launched in 2003, the President's Emergency Plan for AIDS Relief after the Millennium Development Goals, as well as the Global Fund to fight AIDS, TB, and malaria. 19 million lives saved from HIV/AIDS. We reversed the tide in terms of number of deaths. It was climbing steeply, now it's starting to decline. 30% reduction in malaria deaths from use of anti-malarial drugs and bed nets. Not the same dramatic declines that we saw with vaccine-preventable diseases, because we don't yet have vaccines for malaria and AIDS, but still having an important impact. And then we have this, I'm sorry the top got cut off again. We have these other group of diseases, which unfortunately the designers of the Millennium Development Goals of the United Nations actually called them other diseases. And you can imagine from an advocacy and awareness point of view what a disaster it was to call something other diseases, right? You're not going to get Brad and Angelina standing up there saying other diseases, right? It never happened. But so those of us who worked on other diseases got together shortly after the Millennium Development Goals and actually went on this branding exercise to look at 13 or 14 of the most common other diseases of humans, and notice that they have a lot of features in common. Many of them are parasitic infections. They're highly prevalent among the poor. They're endemic in rural areas of low-income countries. Many of them are ancient afflictions. You could actually find descriptions of these diseases in the Bible and other ancient texts, such as leprosy, but there's many more. They're chronic and disabling and highly stigmatizing as well. And the other feature about these other diseases that we call neglected tropical diseases, or NTDs, they both occur in the setting of poverty, and they cause poverty because they reduce the ability of children to grow and develop. They shave IQ points off of kids for reasons that we can go into more later. They impair pregnancy outcomes. They also make people too sick to go to work. So we can actually show that these diseases reinforce poverty. They both occur in the setting of poverty and they cause poverty. So we did a lot of awareness and advocacy about these diseases. I wrote this book on the top right, which my kids always like to call Dad's Forgotten Book on forgotten people with forgotten diseases, as kids can only do. But now it's gone into its second edition. It's in paperback, and it just got translated into Japanese. So I think we're slowly making some headway. Okay, so I'm going to now name, I hope it doesn't get cut off at the top again like the others, but I'm going to name tell you the most common afflictions of people living in poverty, the other diseases. Now I got to see a couple of my students here, so they can't answer the questions, but the others. What's the most common affliction of people living in poverty? Anybody want to make a guess? So there's ascariasis, intestinal roundworm infection. 800 million people have intestinal roundworm infection. A lot of these are worm diseases. This is whipworm. Incredible numbers, right? Hookworm, schistosomiasis, foodborne trematodiasis, dengue, lymphatic filariasis, onchocerciasis, Chagas disease, leishmaniasis, trachoma, cysticercosis, echinococcosis, rabies, African trypanosomiasis, yaws, Buruli ulcer. Endemia is not determined. And there's Ebola on that list of neglected tropical diseases. And basically every single person living in poverty has at least one of these diseases. And most people have multiple infections at the same time. So if you have ascariasis, you also, those who've worked in Africa and elsewhere, you also have schistosomiasis. Or if you have hookworm, there's a good chance you have dengue. And so we're seeing a lot of overlap. People have multiple neglected tropical diseases at the same time. And we're now trying to understand what the impact is. And the problem is a lot of these diseases are not necessarily killer diseases. Sleeping sicknesses, Ebola, but many of the others are long-term debilitating diseases. That's not an easy concept to make people aware of. And how do you translate that? And one of the things that we've done now is create a worm index. We've been able to look at the number of children and adults affected by these neglected tropical diseases in poor countries, and are able to show that as your worm index goes up on the red, your human development index, which is a metric that includes life expectancy and educational attainment, and how you treat girls and women in your community, that starts to go down. The key is trying to find cause and effect, but we're now accumulating that evidence to show there is a direct inverse link between the presence of neglected tropical diseases and the development of your community. The other interesting part of the analysis that we've come up with is, and this was a bit counterintuitive when we first started. Now it makes sense, but but it took us a while to realize what we were finding. What we're seeing is that neglected tropical diseases are disproportionately occurring in people living in Christian majority countries. These are the new diseases of the Christian world. And I say new because of an analysis done by the Pew Foundation, which found that if you look at the year 1910, the 75% of Christians lived in Europe and North America. And starting about 15 years ago, that began to flip. Right now, there are more Christians living in what they call the global south than the global north. So that these are the concentrations of Christians in different countries, and you can see that in the southern part of sub-Saharan Africa, South America, some Asian countries such as Papua New Guinea and Philippines. This is where the world's Christians are living. And so what we did was to do a deeper dive and look at where those neglected tropical diseases are. And we found some interesting things. We just published this in the Public Library of Science, to find that Christian majority countries now account for 1/2 of the world's cases of schistosomiasis, even though they account for about, this is in the leading Christian countries by population, even though they account for 13% of their population. Unfortunately, they're punching above their weight in neglected tropical diseases. So they account for 1/2 the world's schistosomiasis, 1/3 of the world's intestinal worms, basically all of the world's Chagas disease, which is a cause of debilitating heart disease that results in, that's caused by a parasitic trypanosome and transmitted by kissing bugs. Chagas disease, for all practical purposes, is a Christian disease. Sleeping sickness is, for all practical purposes, a Christian disease because it's almost exclusively occurring in Christian majority countries. Zika is it's, if you think about it, it really is the case. So, and this is why I'm so excited that Dr. Osteen and the Lakewood Church, took on this leadership of having a conference like this, because we need to involve religious leaders in taking on these diseases. We're not going to solve these problems without bringing in organizations like the Lakewood Church. They're clearly part of the answer. All right, so what do we do about these interventions? Now, sometimes, we have interventions, but other times we don't. And this creates a real problem, because who's going to make the innovations for schistosomiasis and Chagas disease and hookworm? The big pharmaceutical companies, Pfizer, Merck, GlaxoSmithKline, they do a lot of good work, but they're not going to make the Chagas disease vaccine. They're not going to make the schistosomiasis vaccine. Why is that? Yeah, because they affect a lot of people, right? They're the most common afflictions of people in the world, but they're the most common afflictions of people living in poverty. So there's no financial incentive. So let's look what happened with the Ebola vaccine. So Ebola's rampaging through Guinea, Liberia, Sierra Leone, affecting 30,000 people. 11,000 people died of Ebola. We had no Ebola vaccine. We actually had the science behind the Ebola vaccine published in 2003. It'd been sitting there for a decade because the model is broken. The model says that you develop an exciting, you're an academic scientist or you're working at the NIH, you develop an exciting technology, and then you license it to the big pharmaceutical companies. Well, guess what? The big pharmaceutical companies weren't willing to license it until the US government, through BARDA, through the Biomedical Advanced Research Development Agency, put up $100 million. Then, at the 11th, not even the 11th hour, at 5 minutes to 12, Merck, GlaxoSmithKline, and Crucell turned those discoveries into a bottle of vaccine. They began testing it, and by the time they were getting really into the testing, Ebola was gone. Right? So we still, to this day, don't even know if the vaccines are really working. And 30,000 people died. So it really says that the technology, our ability to make these life-saving products, has outpaced our political, social, and financial institutions that we have to turn them into bottles of vaccine. So we've said, you know what, we're not going to take this, right? We're going to actually do something about it. So what we did was 5 years ago set up at Baylor College of Medicine and Texas Children's Hospital to build what my loving children call Dad's Guaranteed Money Losing Company. But you don't like to call it that. So the Gates Foundation, fortunately, has given it a name. They call them PDPs, Product Development Partnerships. These are nonprofit organizations that use industry practices to make stuff, to make either drugs, and I'm giving you the logos of all of them over here, drugs, microbiocides and preventatives, vaccines and diagnostics. And what we're doing this is the Feigen Center over in the Texas Medical Center, and I invite you to come to visit us. We're on several floors here. We're making a list of products that no one else will make. And now they're advancing through, some of them are advancing through clinical trials. We have a hookworm vaccine that's now in clinical trials in Gabon and in Brazil. Our schistosomiasis vaccine just finished phase 1 testing for safety here in Houston, the Texas Medical Center, and we have earlier stage vaccines as well. So let me just tell you briefly about them. So these are hookworms. Those of you who've worked in Africa and elsewhere will recognize this. It's about 1 centimeter long, and it causes intestinal blood loss. This is one of the major causes of anemia. It's a huge problem in children, but it's also a huge problem in pregnant women. So a third of the pregnancies in Africa are complicated by hookworm. And because they cause intestinal blood loss, they have a huge impact. If you talk to Michael Belfort, who's the chair of obstetrics and gynecology at Baylor College of Medicine, who's from South Africa, what he'll say to me is, Peter, when a woman dies in childbirth in Africa, it's not because she bleeds more. She comes in with a hemoglobin concentration of 6. She has almost no blood in her system because she's been bled out over the 9 months of her pregnancy from hookworm infection. And it's not just hookworm. So in the green there is wherever you have hookworm and malaria co-infections. So hookworm's causing blood loss. Malaria is causing anemia by another mechanism. And so these poor women in labor and delivery have the perfect storm of anemia from those two co-infections. And that bar graph that I'm showing you is showing you that the more worms you have as a kid, the greater your loss in intelligence. They're basically shaving off IQ points. And this concept of neglected tropical diseases reinforcing poverty, my colleague Hoyt Bleakley at the University of Chicago, who's an economist, has found that chronic hookworm in childhood reduces your future wage earning by 40%. So these are the diseases that trap the bottom billion in poverty. They're stealth reasons, but they do it nonetheless. So I won't go too much into the science, just to say that we've worked out this very innovative way, I think, to show how to interfere with hookworms feeding on blood. We can actually elicit antibodies to proteins that line the gut of the hookworm, which are involved in hemoglobin digestion, elicit an antibody response to them, and then when the worm is feeding on blood of a vaccinated individual, the worm ingests the antibody, and like a Trojan horse, it destroys the ability of the worm to feed on blood. And what we've done now is partnered with the Albert Schweitzer Hospital in Gabon, and now we're conducting large-scale clinical testing of the vaccine, and that's moving rapidly through clinical trials. We've gotten some new European Union support for that. And then what we found is wherever you find hookworm, you're finding schistosomiasis. So we thought, well, wouldn't it be nice to make a schistosomiasis vaccine at the same time? And this is an added problem because schistosomiasis is not only causing blood loss, there's now new evidence that's pouring in very quickly that these worms are causing ulcerative lesions on the bladder, but also on the female genital tract. It's a disease called female genital schistosomiasis. How many people have heard of it? So, my students, that's good, and two others. So the problem here is this may be Africa's most common gynecologic condition. That's the interesting thing about neglected tropical diseases. I call them the most important disease you've never heard of. So Africa's most common gynecologic condition, and no one's heard of it. It's now been linked to a 4-fold increase in HIV/AIDS. And if you look at a map of this female genital schistosomiasis and AIDS, it's spot on. So we think this may be one of Africa's most important cofactors in its AIDS epidemic. So far, we're not smart enough to make an AIDS vaccine, but we can make a schistosomiasis vaccine, which will be an important backdoor strategy for HIV/AIDS. Development goals are ending. We're starting to look to see what's next on the horizon, because we're about to enter this new era of what's called sustainable development goals. So we've sunsetted the MDGs, now we're moving into the SDGs, and we've found some interesting facts about neglected tropical diseases. And one of the really interesting, exciting, and sobering ones is the following. With all of that overseas development assistance, through PEPFAR, through the activities of President Bush and continued by President Obama, through the President's Emergency Plan for AIDS Relief, putting on people on antiretroviral drugs, the President's malaria initiatives, the Gavi Vaccine Alliance, we've made a huge dent in the problems of the world's poorest country. But almost like peeling away the layers of an onion, we've uncovered a new problem, and that today, most of the world's, and people are disbelieving when I first say it. It takes a while to sink in. This is a new book I have coming out, and maybe it'll even sell as well as the forgotten book. But most of the world's neglected diseases actually occur in wealthy countries. If you look at the top 20 economies, they account for 50% of the world's worm infections, dengue, Chagas disease, leprosy, tuberculosis, and others. But it's the poor who live amidst wealth that account for the diseases. So it's the poor living among the wealthy in the 20 largest economies that accounts for the world's diseases. So what I'm showing you in the blue are where the poor live in the G20 countries, the group of 20 countries, 20 largest economies, and their diseases. So let's look at a couple of examples. Look at Brazil. Brazil, a wealthy economy. Where is Zika right now in Brazil? Where is it causing all of the microcephaly cases? Right in that blue spot on the right there. That's where Pernambuco State is, and other north. So this is an incredible association with poverty and Zika, like all the neglected tropical diseases. So although Brazil is a very wealthy country, it has intense poverty concentrated in the northeastern part of the country. I tried to get northern Argentina written there because it's not all of Argentina, it's northern Argentina, but couldn't quite do it. China. How many people have been to China in the last? Where'd you go? So you go to Beijing, right, incredibly wealthy city. You go into southwest China, into Yunnan, Sichuan, Guizhou province. You go back in time 80 years, and with incredible poverty and widespread neglected tropical diseases, or northern territories of Argentina or southern Mexico. What's going on in the U.S. there? Do we have poor people in the U.S.? How many poor people do we have in the U.S.? We have 20 million Americans who live at half the U.S. poverty level. And now the University of Michigan has done a study to show that we have 1.65 million families, around 5 million people, that live on less than $2 a day. So the same benchmark you'd use for global poverty anywhere applies to the southern United States. And so being here, creating the School of Tropical Medicine, and knowing that the term neglected tropical diseases is a bit of a misnomer, they're diseases of poverty, we began to take that global health lens and turn it inward, and we found some amazing things. What I'm showing you in the top right is not a study not done by us, but a colleague, Dr. Sarkar at the University of Texas in Austin. That's a risk map for Chagas disease. It's a disease transmitted by kissing bugs that causes debilitating heart disease, and we're finding it widespread in the San Antonio area. We're finding it among the homeless in Houston. We're finding it among even some hunters and campers. And the problem is the cardiologists are not trained to recognize this disease. So it's not being diagnosed. We're picking up cases now through blood bank screening. So people go to donate blood. The Gulf Coast Blood Center tests for Chagas disease. They're told that they have Chagas disease, go to their doctor. They see their primary physician. The primary physician says, we don't have that disease here. I must be a false positive. So we're now working to identify them, and on the bottom right there, we've created a tropical medicine clinic. It's not a traveler's clinic, but a tropical medicine clinic for people in Harris County who have these diseases. On the bottom there is a study done by Christy Murray on our faculty, who found that we've had dengue epidemics in Houston in 2003, 2004, 2005. She found this retrospectively through screening. It was a study of febrile individuals and seeing IgM antibodies to dengue in their bloodstream. Not a single case was diagnosed by a physician. So we have this general lack of awareness, and my estimates are now that we have 12 million Americans living with the neglected tropical diseases. So these are not rare diseases, they're incredibly common, but they're occurring among the poor. So let's talk about Zika a little bit. We're now seeing this extraordinary epidemic that's happening, that's accelerating very quickly. It seems to be going by the chikungunya playbook. Chikungunya came into St. Martin in the Caribbean in the end of 2013, and over the next year spread across Latin America. Now we're seeing, we've seen this before with dengue, and now we're seeing it with Zika virus. So it's in more than 24 countries. It'll be all over the Caribbean by the end of this month, I'm pretty sure. But the point that people aren't really talking about is it's linked to poverty. So the reason why you're seeing so many cases of Zika in northeastern Brazil and the microcephaly cases is because these women are living in extreme poverty. They have no protection against mosquito bites. They live in houses without window screens. They live with environmental degradation in their neighborhood. They have the old tires filled with water and organic debris. And all of these combine to produce the conditions for Zika. We're seeing it march into Colombia, and now it's in the Caribbean. So, and every time there's a big infectious disease crisis, the same thing always happens. It really boosts my media career, and I start going on TV a lot. And one of the things that I'm talking about now that really no one else is focusing on is the link to poverty. So for instance, Haiti. Anybody work in Haiti here? So a number of you. Haiti is going to take a terrible hit, I think. I think we could be looking at a terrible humanitarian catastrophe in Haiti because there's 250,000 babies born every year in Haiti. 250,000 pregnant women, all of them living in poverty. None of them have any protection against mosquito bites. This thing is moving so quickly, we could be looking at 100,000, 150,000 Zika-positive pregnancies in Haiti. We could be looking at tens of thousands of microcephaly cases. We won't know this for another 6 or 7 months, but I'm just terribly worried about Haiti, or Jamaica, which also has terrible poverty. Here's where the two mosquitoes that can transmit Zika are. The Aedes aegypti on the top and Aedes albopictus. So far it's looking like Aedes aegypti is by far and away the better transmitter of this disease. And look where it is. It's all along the Gulf Coast. Where's the poverty in the US? All along the Gulf Coast. So what's going on the Gulf Coast? We have the mosquitoes, we have both, but especially Aedes aegypti. We have the incredible poverty. I think the Gulf Coast is an area that we have to consider highly susceptible to Zika, and that kind of puts me at odds with what the messages coming out of Washington and Atlanta are. The messages are, oh, don't worry about Zika. The country is a wealthy country. We have everyone has air conditioning. We don't have the conditions we're not Pernambuco state in Brazil. Well, this is a quick drive. It doesn't take you long to find. This is a quick drive through Houston's historic wards. It looks like the global health movie you show to the first-year medical students, right? We've got houses with no window screens, houses, or if they have window screens, they're broken. We have standing water. We have the garbage along the side of the road filled with water. We have the discarded tires, which are notorious for breeding Aedes aegypti mosquitoes. So I've been pushing back. Anna Grove, by the way, is my grants and contracts manager, is also a very good photographer. And so I'm extreme. So the point being, the U.S. is not at risk. I push back and say the Gulf Coast is. And this is not, I don't have to work very hard to find this neighborhood. We can go into a lot of the poor neighborhoods in Houston and Aldine and Sunnyside, any of the historic wards. Anybody else live in the Gulf Coast outside of Houston? You can find this around New Orleans, right in Baton Rouge. So I think all of these areas are highly at risk. So then the narrative kind of changed a little bit and said, well, we could have small outbreaks. Well, I don't know what a small outbreak of Zika is. I know what a small outbreak of dengue is. I know what a small outbreak of chikungunya is. People have a rash and fever. But a small outbreak of Zika with cases of microcephaly, I think this is a pending disaster. So we're trying now to really do a deep dive and looking to using that global health lens. Christy Murray and Melissa Nolan Garcia, Alicia Elliott's here, have been looking at some of these diseases. This is Chagas disease. We're finding a lot of transmission. We're now trying to make a vaccine for Chagas disease. This is an EKG of a patient, not a patient, of laboratory animals with Chagas disease, and now we're making a vaccine to see how we can prevent this. I don't have too much time to go into this, but one of the great things about being in the Texas Medical Center, it was founded on the basis of cardiology and cardiothoracic surgery, Dr. DeBakey. So anywhere you throw a stone at the Texas Medical Center, you'll hit a cardiologist or a cardiothoracic surgeon. And they've accredited this incredible, sophisticated biomedical imaging. So we can do studies to show that mirror the Chagas cardiomyopathy that we're finding, and we know this is in Texas, and so we're hoping to advance to clinical trials, and we may actually do the clinical trials in Texas. So I call this concept blue marble health, that it's not your father's global health, we're developing versus developed. We're seeing the rise of all economies, but it's leaving behind a bottom segment of society, and this is something that we're trying to get across. I just want to end, I know you want me to finish up, I'll just end on a few more notes, which is to say the other factor besides poverty that we're looking at is another social force, and that's conflict or post-conflict. So if you look at West Africa, Guinea, Liberia, Sierra Leone, why did Ebola rise there? It's not because it was tropical, maybe that was a part of it. It was because their health systems had collapsed through a decade or more of terrible atrocities and civil war. And this partly allowed Ebola to go throughout West Africa. And we're now seeing that same force in play in the ISIS-occupied territories of Syria and Iraq, now Yemen and Libya as well. Those names got cut off at the top there. But this is what we're seeing. And we actually can't work in those areas because they're too dangerous, so we can only get glimpses of what's going on from the refugees spilling across the borders into Jordan, into Lebanon, into Egypt, into Turkey. We're seeing the reemergence of measles and polio, huge numbers of cases of leishmaniasis, which I'll talk about in a minute, numbers of cases of schistosomiasis, brucellosis, MERS coronavirus infection, dengue, malaria, tuberculosis, Rift Valley fever. This is going to become one of the next big global hotspots for these neglected tropical diseases. And because I don't have enough to do, I took on this additional role with the Obama White House, who's appointed me as his science envoy for last year and this year. And what I've said to the State Department and White House, right now, the Middle East and North Africa has zero capacity to make any vaccines for these diseases, and the big drug companies aren't going to make it. So what I've been doing is taking our Sabin Vaccine Institute and Texas Children's Hospital Center for Vaccine Development at Baylor and saying, we're going to reproduce this now in the Middle East and North Africa. Because one of the great things about us is you can't walk into Merck's or Pfizer or GlaxoSmithKline and say, teach me how to make a vaccine, but you can walk into our facility. So we've been now building capacity in Morocco, Tunisia, and Saudi Arabia to help them start developing vaccines. So this is the last slide I'll show to say that I think how we make the vaccines is going to be important as what we make. And to explain that, I'll tell the story of Dr. Albert Sabin, who we're named after. Sabin didn't discover the oral polio vaccine by himself. It was discovered jointly with Soviet virologists at the height of the Cold War. What happened was, after the Sputnik launch in 1957, the USSR was suffering from horrific polio epidemics. So the guy in the bottom left there, Dr. Chumakov, got permission from the Soviet authorities and the US authorities to visit Dr. Sabin. Sabin went back with him, sent his vaccine strains over to the USSR, and that's where the polio vaccine was first made. It was developed, tested on more than 10 million Soviet school children, shown to be safe and effective, and this is what led now to is leading to the global eradication of polio, two countries putting aside their ideologies to work together for a common purpose in making a vaccine. And I think there's some similarities between that and what we're trying to do now with a lot of the countries in the Middle East and North Africa, and we're making progress now on a number of fronts, so I hope to have the opportunity to come back to you and tell you more about that later. So that's kind of the big overview of neglected diseases and vaccines, and I think we have time for a few questions.
About 7 minutes. About 7 minutes or so.
Okay, thank you so much for listening. Questions? Yes?
What's your opinion on the reports on the internet that Zika virus is not actually increased microcephaly, that it's actually pesticides in these poor countries or other different communities?
Yeah, no, I mean, one of the problems is our publication model for science is outdated. We still publish papers the same way we did in 19th century Germany. So the papers are slow in coming. I happen to see them faster than others because I'm the editor of a major journal in the field. The link is quite clear between Zika virus and microcephaly. And it's not just microcephaly, and this is going to come out in the next couple of weeks. Huge numbers of stillbirths also. So it's both stillbirths and microcephaly. We can recover the virus. These babies are syndromic, meaning they look like they have a congenital virus infection because of the calcifications, like you see with congenital CMV and congenital rubella. We're isolating the virus in the babies from the amniotic fluid. The link is quite clear, number one. It's sometimes said, well, how come we only see the link in Brazil? We don't see the link elsewhere. The truth is, when you go back, the link was there. We just missed it because the numbers were smaller. So the association was there in French Polynesia and Micronesia. And the only reason it's not really happening in Colombia and the other places because Zika just gained a foothold now. So you have to wait a few months. But the link is clear, and we have to proceed as though we're going to see thousands of microcephaly cases, especially in the poor areas of the Caribbean. Yes? So the question is, what do I think about the genetically modified Aedes mosquitoes? I think there's a lot of interesting technologies on there. There's the Oxitec genetically modified mosquitoes. There's the Wolbachia system. There's using mass drug administration with ivermectin. There's using sterile male mosquitoes. I think all of these are interesting and need to be scaled up in a district level to evaluate them. But I think the mainstay for control still has to be old-fashioned insecticides or some of the newer insecticides and getting rid of the standing bodies of water. We need a more aggressive approach using old-fashioned methods that we know work. So not many people are aware of it, but we actually eradicated the Aedes aegypti mosquitoes in 18 Latin American countries during the 1950s. And it was done using a military-style campaign to spray and to remove standing water. We lowered dengue rates, we lowered yellow fever rates. We can do the same thing again if the political will was there. And it's very sad to see that the political will is not being there. And again, going back to Haiti, because I think that's the poster child for this. We're standing by while Hades is sitting duck, waiting for thousands of microcephaly cases to appear. And we can do something about it now that we choose not to do. And I think we've got to figure out a way around that. Yes?
What's the long-term plan for distribution or usage of the vaccines once they move through testing?
So that's a great question. The question is about the global access for the vaccines. And the problem is our organization, Sabin Vaccine Institute, can make them at small scale for small scale clinical trials. We don't have the horsepower for the industrial scale. We're going to need a pharma partner. It doesn't necessarily have to be one of the big multinational pharmaceutical companies. It could be some of the developing country vaccine manufacturers. So there's a lot of horsepower in India and Brazil and China to make vaccines. So we think we're probably going to tap onto that. So we've got a European Union grant now to do a landscaping exercise of all the Indian manufacturers. And they're willing to operate at a lower profit margin than some of the others. They can't lose money on it, but they can operate a far lower profit margin. So for instance, the Serum Institute of India makes meningococcal A vaccine for Africa. They actually make most of the measles vaccines for Africa. And even if they make pennies a dose by dealing with large volumes like these diseases, they can still make enough money to continue supporting their scientists. Yes?
Do you know of any current grassroots campaigns or ways to kind of alleviate the burdens of the
I'm sorry, I didn't hear the last part.
Do you know of any ways and current interventions that are in place to try to prevent Zika virus from being subjected to the?
So the question I thought I heard was that, are there any grassroots initiatives in place for mosquito control in places like Haiti? I'm not aware of them. I got a call from Partners in Health, from Louise Ivers and Paul Farmer, asking for help. They follow a catchment population of about 1.2 million people, including 30,000 pregnant women. They're struggling with what to do. What do you recommend? I mean, DEET and things like that are going to only take you so far when there's, you've got the picture like I showed you in the Fifth Ward with all the discarded tires around everything else. So we need an environmental cleanup and together with mosquito control. Yes?
There was some very promising results with ring vaccination program. With regard to Ebola now, with that ESV vaccination. Is there any public health plans, interventions for distribution of the vaccine, or what are the next steps for that vaccine?
For Ebola. Well, right now, that's a good question. There's a lot of discussion with the FDA and the European equivalent to EMA about licensure of the Ebola vaccine and whether the data is there to award a license. So I think that's one of the things that has to happen. And then a decision needs to be made. I mean, is Ebola a one-time event, or do we need now to go back and vaccinate that population in West Africa? And that, I think, it's a very interesting discussion and debate right now. Yes? So the question is, why has Zika exploded on the scene like it has? Well, you know, it came, and we don't know. I mean, at least I don't know. It was discovered in Uganda in 1947. It was first isolated in 1952. The first case was in Nigeria in 1954. And, you know, when I used to talk about Zika virus, which I did, you know, when I give a lecture on arboviruses to the medical students or the graduate students, you know, you would go through dengue and yellow fever and West Nile virus. Then you'd usually have one PowerPoint slide at the end, Zika, you know, just to check all the boxes that we talked about, all the arboviruses. But we never considered it very important. Then in 2007, we started seeing, you know, big outbreaks in Micronesia on Yap Island. It affected 11,000 people, then 27,000 people in Tahiti, in French Polynesia, then Easter Island. And then things really took off in Brazil. So is it the poverty? I think poverty is clearly a factor that's promoting this. Clearly it's a naive population. You know, 2015, 2016 is an El Nino year where the Pacific Ocean heats up around the equator, and this causes temperature fluctuations and rainfall transitions that are more favorable to mosquitoes. So maybe that's a factor as well, or maybe there was a virus mutation. So far it's looking like the preliminary genomic information on the virus shows it's similar to what we saw in French Polynesia and Micronesia, those first big outbreaks. So if there was a virus mutation, it looks to me like it could have possibly happened in the transition going from Africa as it marched across the Indian Ocean and the Pacific Ocean. But again, everything's very speculative now. That's the frustrating thing about the Zika outbreak. I'm learning more from reading the New York Times and the Washington Post than I am from any one journal because there's so little information about it. It looks like it did but you know, you have to, if you do the back of the envelope numbers, roughly for every 250 to 400 cases that you see a case of Zika. So the reason we saw the big numbers of microcephaly in Brazil was because there's been more than 1 million cases. So you can see 4,000 cases of microcephaly. When you go to Micronesia or French Polynesia where there's 10,000 cases, it might be difficult to see a big bump above background, but when you do a more careful analysis, that seems to be the case. So, so the question is, what happens if a woman has Zika? Will she be guaranteed to have a child with microcephaly? We don't know, probably not. One of the big questions that we have is and this is going to come up if it comes into the Gulf Coast and we start doing sampling of amniotic fluid for amniocentesis for Zika, what do you tell a pregnant mother? Let's say she has Zika. Is the likelihood you're going to have a baby with microcephaly 50%? Is it 5%? Is it 0.5%? We don't have that number to help her make an informed decision. So the emphasis right now has to be on prevention. Cleaning up the impoverished areas of the Gulf Coast, providing window screens to pregnant women who don't have them, and providing appropriate public health advice. And I think we need to start doing that now. Right now, Harris County Mosquito Control is seeing Aedes mosquitoes, but those numbers are going to start to climb as we move into April and May. And that's when if we're going to see Zika, that's when we're going to start to see it. Thank you for the question.
I think we are out of time, guys. The next session starts at 9:15, so just in a few minutes. Thank you, Dr. Hotez. Great information.
Thank you very much.